Okay, if a patient is having pain when manipulated in a CR before loading even begins, are you suspecting that the patient is not completely in CR or maybe intercapsular disorder? Okay, so let me see this again. So if a patient is having pain when manipulated in a CR before loading even begins, okay, so yes, initially, I mean, if I'm not in CR at all and the patient's feeling discomfort, first of all, I stop for a second, I kind of reassess, take a look at my positioning, making sure I'm approaching the patient properly and doing bimanual properly. If they experience pain again, as I try again, I ask very specifically where are they feeling the tension or tenderness. And if they're pointing inside the actual joint space itself and they're actually talking about tenderness there, then I stop automatically and I do start suspecting, oh, maybe we do have an intercapsular issue here. So it's possible. If they're pointing and saying, oh, yeah, it feels like it's pulling, I feel a little tension over here, and they're pointing in front and more towards like either the deep masseter or interior to the joint, then I'm suspecting that it's more of an occlusal muscle or a muscular issue and not necessarily a problem intercapsular. I'm not sure if I'm answering the question exactly as right, but that's...
Well, the main thing to remember is when we're doing a centric relation load test, we're asking the patient two distinct things. Are they feeling any signs of tension or tenderness? And tenderness, of course, would be related to pain as well. And again, when we start to have a patient that's feeling pain, that's identifying a pain response, then we have to be very cautious and always be thinking that we may be experiencing an intracapsular disorder, a medial pole placement, because now the condyle is seating and loading onto retrodiscal tissue, which we know is where the innervation is within the joint system itself. And we have to be very careful. And that's why when we do a centric relation load test, we always start with the lightest amount of loading first. And if we get a positive response for that patient, then we stop, because there's no sense in loading a joint that's painful or tender with any more pressure than light if we're already getting a positive load response. So, you know, getting a positive load response leads us down the path of trying to figure out why that's positive, and then it's either joint or muscle, and one of the two. So, but the answer to that question is that most of the time you're going to find that if you're close to CR or in CR and you're very lightly loading and the patient's experiencing pain, then you have to be very wary of having an intracapsular and a medial pole type of displacement. So that's a great question.
Devin just had a follow-up. He said, for the most part, that answered his question. His most recent patient actually kept pointing at the joint when he put him in CR, or what felt like CR.
Okay. Well, one of the things that we have to remember is that it's our job to delineate between intracapsular and muscular. And if you think about most patients that are experiencing discomfort, you know, I see it all the time with patients coming in my practice, and they think they're having a TMJ problem, and you ask them to point to where it's hurting, and a lot of times they aren't pointing at the joint, they're pointing in front of the joint. And what's in front of the joint is the lateral pterygoid. And remember, the lateral pterygoid, when we're not into centric relation and that muscle can never release, both the superior and the inferior belly stay in a constant state of action or spasm. And a very hot, inflamed, spastic lateral pterygoid, I mean, we all know how bad a Charlie horse can hurt in our leg. It's a very painful thing. So even though that lateral pterygoid is a very small little muscle, when it gets a little Charlie horse in it, it can be quite painful and be very sore. And it's very close to being in that joint space. So a lot of patients, they just don't know anatomically what's going on. They just know that it hurts right here in front of my ear. And most of the time, many patients that think they're having a joint problem, when we take them through the complete examination, when we paint that clinical diagnostic picture, when we deprogram them, we put them on the Doppler, all these things, typically what we often find is that it ends up becoming a lateral pterygoid that's just spasming and it can't release because, you know, it goes in there. So remember, when you have a centric relation hit and slide, you know, your muscles have proprioceptive memory to them. They know where they got to keep that mandible position so that if you bite together really quickly, your teeth line up, right? So when you try to seat somebody into centric relation, that lateral pterygoid knows the joint's not supposed to go there, because if you go there, the teeth don't line up right. And so it's always trying to pull that condyle forward out of the glenoid fossa, just down that eminence a little bit, so that way maximum intercuspation can happen quickly and efficiently. So you're going to see that a lot of times, and that's why it's just so important that we just stay true to our process of our complete examination, do it completely, every step of it, and you'll often find your answer very quickly coming from that. All right, wouldn't muscle palpation of the individual muscles be able to help distinguish the location? Well, absolutely. You know, the only problem there is, well, of course, so muscle palpation is part of our complete examination, right? But our only problem in that is we really can't palpate the lateral pterygoid, right? Because it's internal. You know, we can try to instigate it by having the patient stick their chin forward, and we kind of push on there, but that's a very unreliable kind of diagnostic tool that we get in there. So the way, if we think that if we're trying to delineate between intracapsular or muscular, and if we think the problem is our lateral pterygoid, and maybe our Doppler is telling us that the medial pole is intact, we're not really hearing anything there. Well, when we put them in a Lucia-Jig or any kind of an anterior deprogramming device, you know, within a very short period of time, we're going to have our definitive answer. Because when that lateral pterygoid shuts down, that condyle goes up in the glenoid fossa. It's either going to hurt or it's not. One of the two. So yeah, muscle palpation, don't get me wrong, is critical. It's a critical portion of what it is that we do. And it absolutely helps us to distinguish what it is that we're doing. But the lateral pterygoid sometimes can fool us just a little bit that way because we can't really palpate it.